Good morning and good evening, everyone. We can start right now with Dr. Awda Al-Dahnim. We will start first with the brainstorming cases, and then we'll follow with dermatopathology of infectious diseases. So we can on to you, Dr. Awda.
Thank you so much, Dr. Amin. So today, and we will have an exciting meeting with the brainstorming cases by me, and then it will be followed by Dr. Amin with the dermatopathology. So let's start. So up we go. The first case, as I hope it will be an interactive for everybody. The first case is an elderly patient present with his doctor with a painful reddened papule in a linear distribution on his upper chest. So just take your time and concentrate on the pathology. Where is the pathology exactly? Is it in the epidermis or is it in the upper dermis? We will start with the low power as usual, and then we'll move up to the high power. Just make sure that you keep your mic muted unless you want to um, give the answer, okay? This a little bit under high power. Okay, so what is your diagnosis? Let me just keep the chat box at the side so I can see your chat box. Is it a drug eruption? Is it herpes simplex? Is it shingles? Is it bullous pemphigoid or is it impetigo? We get most of the answer is B. And let me tell you that the answer is C. It is shingles. And let's go up again because usually you'll give me the right answer though. So you can see here within the low power the intercellular edema, and you can see the ballooning degeneration. These are the feature of the viral vesicles. Okay, so you can appreciate it up here in the epidermis. The variable dense inflammatory infiltrate, that you can see them on the upper dermis. With sometimes you can even see the feature of leukocytoclastic vasculitis. Okay, um, up here, okay, you can see the peripheral clumping of chromatin, the multinucleation, which are all a feature with the shingles, the eosinophilic nuclear inclusion that surround the clear hollow, which called the ground glass appearance. So these are really typical feature of shingles that cannot be missed. Okay, within either the cantholysis as well that you can see in the reticular degeneration. So yes, it's a typical case of shingles.
Sorry, do you mind saying the feature that you said is specific to shingles again? I couldn't really hear you.
The multinucleation, the peripheral clumping of chromatin, the eosinophilic nuclear inclusion with the clear halo, which is called the ground glass appearance, with the ballooning of the nucleus. So these are the feature of the shingles.
So
Most classic.
how would this be different from just a regular HSV infection?
You will not see much of the multinucleation though. Within the because you know usually even with the shingles you see the grouped vesicles all together, and clinically so that reflect histopathologically as well. Okay, so that's kind of a classical what we see the all the multinucleation all clumped together, and you can see it in the low power as well. Okay, of course it will help a lot even with the because he's an elderly patient as well. Painful reddened linear distribution on the upper chest, so even the clinical history that goes more into toward shingles as well. Okay, so let's go into the second case. So case 2, he's a 15 years old boy, present to his dermatologist with a painful plaque on his heel. Okay. Hopefully this one is much easier. You know the answer before I put the multiple choices, and you can give me the answer though. There we go. Okay, so what is your diagnosis? Is it herpes infection, plantar wart, like in Syphilis chronicus, or Burukis carcinoma? Okay, so this time is all agreed for plantar wart, and yes, that is the correct answer. You know that plantar was caused by HPV virus. So do you know which type of HPV virus? Just a quick recall.
3 and 11? Maybe not.
1, 2, 3, 4, 27, 29, 57. Yes, Dr. Jawahar. So try to remember them. They're very important as well. So if we go up again, just to quickly. So from even the low power, you will see the Burukis lesion. It's either it's usually endophilic component, and you see the marked acanthosis with the numerous enlarged eosinophilic keratohyalin granule, the hypergranulosis as well, and the most specific, the collucite that they are very specific, and you can see them, appreciate them here. Okay, and sometimes you see the thrombosis of the dermal blood vessels as well, because even when you even scrape the verrucous, you will see a pinpoint bleeding, and that represents the thrombosis of the blood vessels. Okay, so that was a quick and easy one. So plantar wart.
Can I say one thing? Sorry. When you're, do you mind just using the cursor to point things out too, if you can?
So the
So
collucite, is it?
yeah, just when you say, "Oh, this is a Jimmy," if you can just point it out, that would be a good
Here,
reinforcement to remember too.
these
Thank
are all the collucite.
you. Thank you.
Here, okay. So they are very specific. Even from the low power, you can appreciate them a little bit, okay? But still, you have to go to the higher power if you are not that much confident till you see the collucite, because these contain the numerous virus, okay? Okay, so case 3. Hope I'll not go quickly, so we'll leave time for Dr. Amin as well. So a 30 years old man with a known HIV infection present to his physician with an acneiform eruption. Acneiform eruption, okay? So this is the low power. Okay. Okay, so what is your diagnosis? I can go back if you want to. Is it miliaria, cutaneous candidiasis, pseudomonas folliculitis, Petrosporum folliculitis, eosinophilic pustular folliculitis? You can just have a quick look again. Concentrating up here. I'll give you a little bit of a hint. Everybody will say E, but it's Petrosporum folliculitis. I think this time my case is a bit difficult. So it is Petrosporum folliculitis, and you can see that up in here, even with the low power, that the blood distended from the follicular infundibulum. Okay, so that's a Petrosporum folliculitis. Okay, and that contain usually the keratin. Even inside, you can see, appreciate the keratin depressed with a multiple budding and oval round yeast. See here, I give you the clue. It's all full of yeast. Okay, and even sometimes the follicle will rupture. You can see some of the abscesses formation, granulation tissue as well. So that give you the clue. And you know that Petrosporum folliculitis caused by? What is the cause of Petrosporum folliculitis? Yes, Malatia farfar. Yes, Dr. Ghassan, yes. And of course, to confirm the diagnosis, you have to do staining. You can either do the PAS staining or the GMC staining. Remember your staining, this is very important, okay? So just to confirm your diagnosis, don't miss the small thing, okay? Okay, so up we go, case number 4. So this time I give you the clinical history as well. The clinical picture. In this condition, infection with what human papilloma virus is most likely to progress to malignancy? So you have the clinical picture. I have only one of the histological view, and this is very specific. Okay, so which HPV type that can progress to malignancy in this condition particularly? So you have to get, the diagnosis at least, so you can go with the HPV that can progress to malignancy. So which one? Is it 6 or 16, 3, 10, or 5 or 8? You can just type in or shout the answer, it's fine. There is no as such as right and wrong on it, so we're just revising. Some are agreeing with B, some will go with 16, the other with E. And yes, the correct answer is 5 and 8, because this case, it's actually Epidermoplasia Virus, if you do remember, which is usually an autosomal recessive. And you will appreciate the mild epidermal acanthosis, the hypergranulosis, the enlarged keratohyalin granule. And so if you go to a bit of a higher power, you will appreciate sometimes the dysplasia of the keratinocyte, even the clinical picture as well. And he's in his early adulthood. So yes, it is epidermodysplasia verruciformis, and type 5 and 8 will progress to malignancy. Very important. Okay, so well done to all who said E as well. Okay, so case 5, 5 years old girl present to her pediatrician with a multiple oval round lesion on the face and limb. Okay, it's under the low power. Higher power. It's actually Dr. Amin and me, we discussed this before, so guess it will be easy for everyone. So what is your diagnosis? Is it herpes simplex, warthitis, keratoma, chickenpox, molluscum contagiosum, or measles? Yes, Dr. Jawahar, and well done to everybody. Actually, it is Molluscum contagiosum, well done. And yes, Dr. Jawahar, Henderson, Patterson body, this is very important as well. This is the classical feature of Molluscum contagiosum. Do you know which virus causes molluscum? Which virus that causes pox virus? Yes, that is correct. And you can see that even from the low power, actually, from the low power, you see the endophilic and exophilic, proliferation with a crater like in the center of the lesion itself, with eosinophilic inclusion body, would call the molluscum body or Henderson-Patterson body. These all contain the virus. Okay. Yes, that was an easy one. Okay, case number 6. So 42 years old male, HIV positive patient, present to his primary care physician with a new onset of maculopapular rash and oral ulcer. Okay, so the have a bit one of the clinical cases. Concentrate on the middle of the lesion as well. So we are going into a higher power. Okay, what are these cells? This one. So what is your diagnosis? CNV infection, polyarthritis nodosa, leukemia, angiosarcoma, herpes infection. You want me to go back again? Yeah, I guess all of you know what is this cell. So what is it? What does it called? So it is a CNB infection. What does it called? Yes, yes, Dr. Ghassan, it's the owl eyes. It's very classical for CMV infection. And usually we don't see much of the CMV infection on the skin, but since he is an immunocompromised patient, so we have to keep an eyes and for every single skin lesion that the patient develop, with this enlargement of the cell, it's called owl eye with the nuclear inclusion. And you can see other features. If they have all of the mix, even inflammatory infiltrate on the dermis, um, prominently the neutrophilic, but they have a mix of inflammatory cell as well. The most important is once you suspect, you have to do immunochemistry as well, just to make sure of and to confirm the presence of the CMV infection. Okay, so yes, these are the owl bodies. Okay. So the last case, okay, a 34-year-old woman present to the dermatology clinic with a pruritic red nodule on her scalp following a recent trip to southern Mexico. Okay, concentrate on some of the specific feature that we can see here. So what is your diagnosis? Onchocerciasis, tangiasis, scabies, cysticercosis, or myiasis? You want me to go back one more time? Can give you like a 30-second. So what do you think? Any clue for the answer? Anyone? Well, yes, absolutely yes, it is myiasis. Well done to the US people. Well done. So that's caused by dermatophobia hominis, the most commonly. And yes, you can see it under the light microscopy. These are the skeleton of the larva itself. Okay, I just put here is the full larva, and here you can see the skeleton of the larva. So these are the one that we saw up here. Okay, so these are the skeleton of the larva. Okay, and sometimes you can even see the muscle, and sometimes even you can see the visceral of the larva itself. You can see they can cut it up here so you can see this part, but they give you the clue with the skeleton of the larva. So it is myiasis. Okay, so you have to keep an eye for each and single thing around the slide itself. That will give you the hint. Okay, and even his trip to Mexico. That is most commonly for the larva and the infection with the myiasis. Okay, so thank you. That take us 20 minutes for the cases. Hope you like the cases. Pigmented no, actually, yeah, but you can see the skeleton. Actually, this is the clue from the clinical history, then from the histopathology part with this one. Okay, so I make sure that I put this one so you can see a part of the larva. Okay, thank you all. So all to you, Dr. Amir. So I hope I make
Yes,
your
thank you.
it easy with these interesting cases.
Yeah, thank you. They were very interesting. Some of them now I can skip parts of my presentation and get to finish faster, which is good. If anyone has any questions regarding the last cases, you can ask Dr. Rauda, and I will start setting up my part of the presentation. Um, and we'll start in a few minutes. Okay, let me know if you see the screen. If you do, we will start in 2 minutes time.
I need.
No, to answer your question, the screen is not frozen. We'll be starting in a minute. Okay, shall we start now for whoever is here? Okay, let's see. So that I can know who's attending, so I know who to ask. Okay, very good. Okay, so we'll go to the first case. I will describe the features, and you can answer as soon as you know the answer. Let's make this interactive, and If you have any questions, don't hesitate to ask. Preferably if you want to answer but with the voice, but if you can't, you can type your answers and I'll see them in the chat box. So first case, can anyone tell me what this is?
Condyloma.
Okay, condyloma is a possibility, but why is this less likely to be a condyloma and more likely to be a verruca? Or a VV, let's say, verruca vulgaris. You know, condyloma implies a genital lesion. The features of the stratum corneum tell you more that this is more of acral skin rather than genital skin. And yes, like Johar has said, one of the features that would favor verruca vulgaris is the inward curving of the rete-ridges. As you can see here, they're beautifully curving inward. And then other features that you would find in any kind of wart or most kind of wart is the coilocytes here. You can see the cells with shrinking nuclei. Hypergranulosis, which can be, you can see in most warts. You can see here how far the granular is going. And then you got your towers of parakeratosis in certain areas, and certain areas you don't have parakeratosis. You can see here the parakeratosis. It's characteristically rounded. Parakeratosis of warts usually takes this rounded shape, which also helps you identify them as warts. So we started with an easy case. Let's move on. What is this? Starting with low power, if anyone can tell me what's going on here.
You have an intraepidermal vesicle.
There's an intraepidermal vesicle, very good. So what kind of vesicle is this? Is it a spongiotic vesicle, or is it an acantholytic vesicle, or is it a necrotic vesicle, or what kind of, what do you think the process led to, that that led to this blister? So acantholytic, and yes, HSV is the diagnosis here, as MK says. You can see here, this is where the money is. You got your, it's been described very well earlier in the presentation by Dr. Alva, but just to touch up on it again, you got your multinucleated cells, even when they're a single nucleus and before they become multinucleated, so this one is coming to join these cells, you can see the eggshell of chromatin and the clearing in the center. Without history, it's difficult to 100% confirm whether this or any other case would be a HSV or VZV. Certainly with the epidermal features, they're pretty much similar, but with the dermal features, varicella virus usually causes a more intense infiltrate in the dermis, sometimes to an extent that can cause vasculitic changes. Like, you know, just by seeing the dermal infiltrate here, I would think more towards a varicella, but you can't say for sure. History is the most important thing to differentiate the two. Okay, let's move on to our next case. What's going on here? Let's say this is an immunocompromised patient and has many lesions all over the body. Epidermoplasia Virus is very good to Hejan and Amy. You can see here the distinctive feature in EDV is these bluish cells. You can see instead of cells shrinking up, they actually become larger. The nucleus still remains like shriveled, but the cytoplasm is huge and very bluish, and goes on, starts with the granular layer and goes way deep into the spinal layer, as you can see here. These are very distinctive features. EDV, or epidermal dysplasia versiformis, has two main forms: the rare hereditary type, which it is caused by EVER1 and EVER2 gene mutations, and the acquired type, which we see much more often, mostly in individuals with the HIV or AIDS. let's see another lesion. See, let's say this is the genitalia of a patient, genital area of a patient with multiple lesions.
Boinoid papulosis.
And if I, why Boinoid papulosis?
It looks like an SCC, like a Bowen's disease, except.
Or it looks like an SCCS.
Wait, no, it's not mucosal actually.
But it's SCCS. It's genital skin, as in you know when you like, you know, suprapubic area. So you can see here the epidermis itself. You can see huge atypia. You can see atypical mitotic figures here, large pleomorphic cells. So where do you expect to see lesions of Bowenod papulosis? It's in the usually around the genital area, and both in the mucosal and cutaneous parts of the genitalia. It's important to identify this because usually Bowenod papulosis has better prognosis than other lesions like, you know, Buschke-Lowenstein. Bowenod papulosis, even though it looks bad and usually multiple, sometimes it even just self-resolves and goes away. But regardless, it has to be treated. Which kind of HPV viruses can cause this?
16, 18.
16 and 18, correct, and 31, 53 to a lesser extent, and then there's many other types which you need not bother knowing. Moving on to our next case. What would this be? Anyone?
That's a condyloma.
It's a condyloma. Again, we have genital skin here, or let's say the cutaneous part, component of the genital skin rather than a mucosal part of the genital skin, because you can see a good stratum corneum. But condylomas can really be confused with the seborrheic keratosis, which also can occur in the genital areas. Especially since condylomas can have very little hypergranulosis, can have very little chorocytes all over them. But what distinguishes condyloma, if it lacks these features, is two main things actually. First, the rounded base. If you can see here, see they're all like really rounded. With seborrheic keratosis, they tend to be flat based. Condylomas tend to be rounded in the base. And another feature is the nuclear streaming. As you can see here, look at the cells going all behind each other, like, you know, like a stream of nuclei. This feature you would not find in seborrheic keratoses, and you would find them mostly with condylomas. These are not coilocytes here. This is artifactual clefting between the nucleus and the cytoplasm. So don't confuse that with coilocytes. But yes, this is a case of condyloma. Sometimes confused with the seborrheic keratosis if it lacks the hypergranulosis and the coilocytes, but it can be distinguished with the two features I just mentioned. Next, what process is going on here in the epidermis? Is it healthy or is it being damaged? So MK says acantholysis. This is not acantholysis. This is not a process of acantholysis. These are inflammatory cells inside. So necrosis, yes. So there is necrosis in the epidermis. So what kind of necrosis is going on here? Is it ballooning necrosis and degeneration? Is it reticular degeneration? Is it apoptosis? Dyskeratotic degeneration? What kind of damage is going on necrosis in the epidermis? MK says ballooning. Look at the strands here, forming like a net-like pattern. Is this characteristic of ballooning or reticular degeneration? Look here. Look at the strands. So there's more like a reticular degeneration. So what entities or infectious entities that you know of cause a reticular degeneration in the epidermis? So hand, foot, and mouth disease is one of them, which is correct. And ORF is another one. Very good. So what if I told you that this patient has only one lesion in their index finger? Which one would you say? ORF. What if I told you there are multiple lesions in the hands and feet of a young patient? You would say hand, foot, and mouth disease. These are definitely the two most common causes, but all other kinds of pox viruses, apart from molluscum, can give you these reticular degeneration features. For anyone who's using the audio, please close the audio, or I will remove you from the chat, from the presentation. So yeah, what we have here is reticular degeneration, and like I said, the features could be seen in hand, foot, and mouth disease, and any kind of pox viruses like the smallpox or milker's nodules, cowpox, not Molluscum Contagiosum, but variola as well. Keep these conditions in mind when you think of a differential diagnosis, and history will always guide you. See our next case. This is a cool case for the smart people here. Let me just look for a place where there's a good features. No, not this area. Here. This is what I want you to see. So what is this? This is also an immunocompromised patient. If you don't know the answer, I'll give you more hints as we go on. But it would be cool if any of you knew this early on. This is very distinctive. You wouldn't see this feature in any of the conditions. So trichodysplasia, or viral associated trichodysplasia, from Mish'al, who still is not willing to buy a microphone. So you can tell us in the chat box, Mish'al, what features favor trichodysplasia of immunosuppression, viral associated trichodysplasia spinulosa, which usually presents with papules on the nose. What features here on histology made you think that this is trichodysplasia? So yes, there's a lot of trichohyalin granules all the way to the top of the hair follicle. Normally, trichohyalin granules are found in the lower part of the hair follicle. It's not just going all the way up, but involving almost an entire shaft of the hair, or where the hair is supposed to form a shaft. And in the end, a hair shaft is not formed. If you can see all the way up, there's keratin, there's granular layer, but there is no hair shaft. The hair shaft cannot be formed with this thick inner root sheath. So yes, this is trichodysplasia of immunosuppression. Very distinctive. You will not see this feature in any other condition. The condition itself is very rare. I've only seen like a couple of these throughout my whole career, and both cases were patients who had it was transplant patients. Next case. What's going on here? What process is going on in the epidermis?
There is subcorneal.
There is subcorneal, very good. Subcorneal clefting. And what kind of cells are inside mostly?
Like I see a lot of neutrophils.
There's a lot of neutrophils. And what is this, like, bluish, schmutzy material? What do you think it's going to be?
Bacteria.
Maybe bacteria. Very good. So with this picture, what do you think the diagnosis will be?
Bullous impetigo.
Bullous impetigo. Very good. Very simple case here after the difficult one we just had earlier. So bullous impetigo here. Very good. And another one here. What process is going on here?
Also subcorneal.
Also subcorneal clefting, very good. Also subcorneal clefting. But how does this subcorneal clefting process differ from the previous one we just saw?
This is post-inflammatory.
This is post-inflammatory. No, barely any inflammatory cells, barely any clumps or colonies of bacteria. Let's say this was a generalized process. What would you think this is?
Post.
So Staphylococcus SSSS, Staphylococcus scalded skin syndrome. So don't be fooled by this image. Sometimes you do find some inflammatory cells. This is an extreme case with absolutely no inflammatory cells, but sometimes there is. But the difference is between this and bullous impetigo, other than clinically where this would be like, widespread, histologically, if you stain it with granthine, you wouldn't find any organisms. So Staphylococcus scalded skin syndrome, it occurs mostly in young individuals, but older individuals, especially those who have renal failure, because those patients can't release the toxins from the body as quickly as healthy individuals. So those patients are very prone to get SSSS, and in those patients, the prognosis is pretty bad.
Couldn't this also be pemphigus foliaceus?
It could be pemphigus foliaceus, but pemphigus foliaceus tends to be more inflammatory with much more acantholysis, which I hardly see here. There's very little acantholysis. There's some here, but there's very little acantholysis, and there's no inflammatory infiltrate. You'd expect some eosinophils or neutrophils in pemphigus foliaceus, which I don't see here. I personally confuse pemphigus foliaceus more with the bullous impetigo rather than scalded skin syndrome, just to give you an idea of how inflamed I expect foliaceus to be. Next case. So let's see, this patient presents with the purpuric lesions, a lot of purpuric lesions in the hands and feet mainly. Does anyone want to comment on the blood vessels? Do they look normal, or do they have like a thickened eosinophilic wall?
Thickened.
So they look thickened. They're starting to be damaged. So there is somewhat of a vasculitis going on here. Especially look at this vessel, thickened fibrinous wall. But the infiltrate is mostly lymphocytes rather than neutrophils, which you would expect to see with a leukocytoclastic vasculitis. So what entities would give you a lymphocytic vasculitis?
Glove and Stock syndrome?
Glove and Stock syndrome? Not really, no. I mean, less to a very mild extent, but not much of a vasculitis. Sorry. Perniosis, correct. Rickettsia, correct. Dagos would also cause this. And okay, so we got a perivascular infiltrate. We don't have much of an interface dermatitis. So if I told you that this patient has high fever, papules of purpuric papules on the wrist area and ankle area, what would you think the diagnosis would be?
Rocky Mountain spotted fever?
Rocky Mountain spotted fever, so rickettsial infection. Very good for both of you, Michelle and Ruth. Moving on to the next case. Let's say this is an immunocompromised patient. Presents with these large lesions. And as you go deep, you can see that this is a very vascular lesion. You can see here. Vascular, a lot of blood vessels, a lot of neutrophils, and this. I don't know if you can see what I'm pointing at.
Basilar Angiomatosis.
Basilar Angiomatosis. Very good, Amy Wang, even though I'm surprised how hard it is for you to pronounce that, given that you make a harder diagnosis. I'm just messing with you, by the way. So, yes, this is Basilar Angiomatosis. Clinically, it looks like pyogenic granuloma, but usually it's multiple and occurs in immunocompromised individuals. What distinguishes it, as you can see again with the general outline. See, when you see things at low power, it gives you an idea how the thing looks clinically. So when you see like this exophytic papule or nodule, and you can see the epidermal ridge curving around that, you can expect it to be like a papule with a collarette of epidermis, which you would expect with a pyogenic granuloma. But when you go deep, pyogenic granulomas, even though it's called pyogenic granuloma, it doesn't have much neutrophils inside it. But this one has a lot of neutrophils. And then the purple areas, which represents clumps of bacteria, really seals the diagnosis for you. So this is Basilar Angiomatosis. It's caused by infections due to which organisms? Bartonella, very good. Bartonella hensela. And what else? What other organism can cause it? Bartonella cuntana, very good, both of them. And cuntana can cause also another kind of, I think, relapsing or trench fever. And Bartonella Bartonella hensela can cause cat scratch disease. Very good. Okay, this one is easy. I think I'm just going to skip over this one. Someone answer quickly so that my feed into my OCD of answering every question. Okay, very good. Molluscum Contagiosum. Next case. So what part of the body do you think this is? Just from low power.
The ear or the nose?
Okay, so you got, I mean, that is a perfect answer. So what you meant is an area where there's cartilage nearby. So by being dermatologists, we think of usually the ear and the nose as our very good friendly cartilaginous structures, which we deal with on a frequent basis. So this is either the ear or the nose. I would say more likely to be nearer to the nose here.
The sebaceous glands?
What? Because of the sebaceous glands, yeah. So we would be closer towards the nose, but you got it right. So you thought of an area that is close to a cartilage, which is very good. So let's go close and see what's going on here. So there's a huge inflammatory infiltrate consisting of a lot of histiocytes, which you can see here. They're foamy, and there's neutrophils. So when you see this, you think of infection, of course. And if you don't think of infection already, given this the title of this lecture, so you got these cells. So a lot of foamy histiocytes and a lot of plasma cells, that you can see here. And some of them are pretty large compared to usual plasma. Look at this plasma cells. I would say it looks pregnant, but it's rude to say that now because sometimes they're not pregnant and they might feel like offended. So a lot of pregnant looking, let's say, plasma cells, and a lot of, okay, very good. Rhinoscleroma to the sun and Mishal, very good. So rhinoscleroma caused by which organism? Klebsiella granulomatous, very good. Okay, so let's move on to the next case. You guys are doing really good today. Okay, on low power. This should be easy. Anyone? What's going on here? I got granuloma. And you can think of your granuloma as this conditions. And Amy Wang says TB, and I think she said that because she noticed the caseation in the center, which is correct. So whenever you see caseating granulomas, you can think of TB. Michelle says LMBF. You're correct in terms of thinking of a tuberculoid lesion, but think LMDF is usually much more superficial in the epidermis. This is really deep and subcutaneous location. You will not find LMDF in a subcutaneous location. It's usually superficial. So EI, that could be, yes. But generally speaking, I'm trying to show you a lesion of TB. And let's say we stained it here. What stain do you usually use for TB? Phyte stain, very good. So we can use phyte or acid-fast stains. The lab I work in, we mostly stain with the phyte stain, and with the phyte stain here, you can see these tiny, what we call them, the red snappers. So the mycobacteria here, if you can see them all over the. This is the highest power I have. But very good. So zeolnithin is same as acid fast, and or phyte. We can use the phyte stain. As you can see here, lots of organisms. They're very, very tiny. Many of them are intracellular. Okay, moving on. Low power diagnosis. The granuloma coursing towards the nerve. Very good. Leprosy. What kind of leprosy would you think this is? Tubercular leprosy. Very good. So you got your granulomas here involving the nerve coursing towards, not that much diffused toward the dermis. And clinically, it will present with just a couple of patches, not even plaques. We got another case here. What would this be? Oh, look at this. A lot of granulomas, a lot of giant cells here, diffusely involving the dermis. So this is Lepromatous Leprosy, and we just saw a lot of globi, Burko cells or globi. You can see here. If you stain these, you'd see a lot of organisms inside. And this is another type of leprosy. A smart one would tell me what type of leprosy would this be. You see there's a huge fibrosis in a patient who had leprosy a long time ago with long-term treatment. And again, we can see a lot of globi here. Histoid leprosy, very good, Mahmoud Ali. Histoid leprosy, and again, with the phyte stain here for the histoid leprosy, we can see a lot of organisms, Very good. Let's go on to the next case. Oh, look at this. So we have a dense neutrophilic and granulomatous infiltrate surrounding this thing. What is this?
A green.
A grain, very good. So this is a grain. The grains can represent actinomycosis, could represent a mycetoma, whether it is eumycotic or actinomycotic mycetomas. It can be hard to differentiate the two, but usually the grains of fungi are usually much larger than the grains of bacteria. And you can see here very nice Splendor-Hopley phenomenon around the grain. Culture is usually the preferred method to distinguish which organisms in order to direct treatment, as you can see here. This is a fungal, by the way, but it could be either way. And size-wise, I think maybe the only hint here that it's morely fungal, but again, could be bacterial. So don't think there isn't a single criterion that would make you confirm a diagnosis. You have to culture it to know what the organism is. Let's move on to the next. This is a very sick patient. Look at this. Over here. Yeah. What's going on with the blood vessels?
DIC.
So DIC, and if we're thinking of angioinvasive fungal, we don't see the fungi here, and angioinvasive fungi usually involves deeper vessels. What we see here is a large process of coagulation in the blood vessels, if you can see here. And some vessels are actually also inflamed with some leukocytoplastic changes and dirty necrosis. So this is a case of septic vasculitis with the DIC. What do you think the causes of this would be?
I think staph is the most common, right?
Staph is common, yes. What else?
Staph.
I would think something even more important and more frequent than staph, actually, because the large areas of purpura fulminans and usually fatal, if not diagnosed really early. Meningococcemia, very good. So meningococcemia, the purpura, especially the gunmetal gray purpura and the huge bleeding in the skin usually occurs due to two main processes. First of all, the coagulation, which is a DIC process, but also due to septic vasculitis. So you do get two types of lesions in meningococcemia and possibly staph, post staphylococcal, post streptococcal DIC. But if you see a lot of septic vasculitis, you would think more of meningococcemia, because that one is an actual active condition, and usually staph and septicoccal are usually post-infection rather than during the infection. Meningococcemia is very important to diagnose really early. Skin biopsy for both culture and histology is important, not just for histology, because culture has been shown to give almost as good yield as doing a spinal tap for the patient. So if diagnosed early, patient might survive, but if seen by the time all the purpuric and bruise like patches develop, that's usually too late in the diagnosis. Let's move on to our next case. This is a low power diagnosis. Syphilis, very good. So this is probably a secondary syphilis. The certain features of syphilis that we can see here is elongated rete ridges, superficial and deep perivascular infiltrate, some interface dermatitis, as you can see here, and dense infiltrate containing a lot of plasma cells here. See here, plasma cells here. There's a lot of plasma cells all over the place. The plasma cell here, a lot of histiocytes. So this is a case of secondary syphilis. Again, what gives the diagnosis is it has a somewhat psoriasiform hyperplasia of the epidermis with very long rete ridges. The infiltrate is really dense between the rete ridges. When you compare it to many other interface dermatosis, it doesn't usually show this. They don't usually show this dense infiltrate between the rete ridges that you would see with syphilis. It's really, when you see it in low power, you can't tell where the rete ridges is and where it isn't because of the dense infiltrate. And it usually has a dense superficial and deep infiltrate with syphilis. Moving on to our next case. Can't see anything in the dermis. So let's look at the epidermis and what's going on here.
TV.
TV, which stands for
Tinea versicolor.
Tinea versicolor, very good. So tinea versicolor, you can see your short hyphae and a lot of spores here. And the fact that you see it very well without the PAS stain also testifies for it to be more of a TV rather than a regular tinea corpus or any other tinea. Don't get me wrong, there are chances where you might be able to see the fungal hyphae with the regular tinea, but tinea versicolor much more readily shows itself on H&E and without the PAS stain. So very good. So you got your yeast forms and you got your hyphal forms. So very good. Next case. So this one has a PAS stain, and we can see stuff going on here and here. What is the diagnosis here? Candida, very good. So Candida, and Candida has its yeast and pseudohyphae because of several yeast forms getting next to each other. But the vertical arrangement of the yeast and pseudohyphae is what makes Candida very characteristic here. So this is Candida, very good. Next case. What process is going on here? What structure is inflamed? What structure is getting inflamed here?
Hair.
The hair follicle, very good. So let's go a little deep in the hair follicle. As you can see in this power, what's going on here? So fungi, very good. And when you have a dense granulomatous infiltrate that goes really deep in the hair follicle, as you can see here, dense granulomatous infiltrate and fungi inside the hair follicle. What do you call this?
Mycosis granuloma.
Mycosis granuloma, very good, very good. Moving on to the next case. Let's see here. What is going on here and here with the PAS stain? So tinea, very good. So this is a case of tinea. I don't know if someone said it or not, but when you need a PAS stain to identify the organisms, and when they're like mostly, if not all, hyphae, you think of tinea, whether it's tinea corporis, tinea cruris, any tinea would present this way. Okay, moving on to our next case. Last one was pretty easy. Let's see this one. What's going on low power? What happened to you guys? You're all asleep now? MK. What's going on here? So we have a lot of giant cells, yes. Let's see, let's comment. The epidermis is becoming a little acanthotic as well. That also should give you a hint because this will present with a thick plaque.
Chromomycosis.
Chromomycosis, very good. Look and see them here. The copper pennies or medullary bodies, brown organisms. Very good. So, and many of them are inside the giant cells. So this is chromoblastomycosis, very good. Next case is, what's going on in the epidermis?
Some parts are acanthotic.
So acanthotic, but it's more than just acanthotic. It's pseudoepitheliomatous hyperplasia, very good. So PAH, when you see a PAH, and you see in the dermis, there's a lot of neutrophils and a lot of histiocytes, you immediately think of a deep fungal or multibacterial infection. These are the two big causes of PAH with this kind of infiltrate, both granulomatous and neutrophilic. So let's look deep to see if we can find any organisms. I don't see any. And that should be a hint to what this organism is likely to be, because if it was chromomycosis, blastomycosis, mycosis, we would see some large organisms, but here we don't see any. So I will resort to using a GMS stain, which I gladly have here. And these are the organisms I see. So you can, so based on the information we already have, we got pseudoepitheliomatous hyperplasia, neutrophilic and granulomatous infiltrate. And this is the shape of organisms, which we cannot see on H&E.
Spider truck.
What?
Spirotrichosis.
So sporotrichosis, very good. This the tiny cigar-shaped organisms which can be hardly seen. It gives you a hint towards sporotrichosis. Clinically should be also obvious, given the characteristic presentation or distribution of lesions in sporotrichosis. Next, again, what do you see here? On low power, we see pseudoepitheliomatous hyperplasia again and again on H&E. We can see a lot of neutrophils, a lot of eosinophils, and a lot of histiocytes, and these tiny organisms. You can see them here. So let's use a stain to help us identify the organisms, which are like, rounded here, small rounded organisms. You can see here. This is how they look like on the GMS stain. What would the diagnosis be now? Blastomycosis, very good. North American blastomycosis with wide based budding and usually single budding pattern. Very good. Next case, again, same thing. We got a pseudoepitheliomatous hyperplasia, got a dense infiltrate in the dermis, and what could be also foreign stuff like, organisms here. As you can see here, this could be an organism. Usually in H&E, you get a hint, but never confirmation. Like this, for example, I can tell you that this is not an epidermal cell. It's not any of our well-known inflammatory cells, these structures. So, it could be cryptococcosis. Good job, Amy Wang. It could be. Again, look at them here, the budding. So let's use our GMS stain. Let's try to identify these organisms. Okay. You want to modify your answer now? Look at this. Paracoccidioid mycosis, very good. South American blastomycosis. You can see organism with multiple buddings. It is very hard to tell on H&E, but with the GMS, it becomes much easier to identify. Very good for all of you.
How can you differentiate between that and blasto? Kind of looks similar.
As you can see, first of all, the organisms of paracoccidioid can grow to much larger spores. As you can see here, we didn't see blasto is not usually at that big. So paracoccidioid, first of all, the organism is larger, and second of all, the multiple budding. Multiple budding, you rarely or hardly ever see it with blasto, but you see it very frequently with paracoccidioid mycosis. As you can see here, look at this one, for example, multiple buds all around it. This one as well, multiple budding around it. This feature you would not see it not commonly see it with the blastomycosis. If you want to go and think how do we practice, usually even with these features, we'd always have to rely on a culture diagnosis to confirm 100%. But for academic purposes and just knowledge purposes, size of spores, as you can see here, the paracoccidioid is actually much larger, and it has its multiple budding, as you can see here, compared to blastomycosis.
Okay, thank you.
Sure. Okay, next case. Trying to find the cells that matter here. Not these. Sometimes when you look for them, you just don't see them. Oh, there it is here. Look at this. What are these? So without formalities, there's like, a neutrophil, granulomatous, it's an infection. It's probably not a bacterial because it's really large. So Anki said spherulo. What does that mean? Did you mean the spherules of a certain organism? Yes. Are you talking about coccidioid mycosis? Coccidioid mycosis, very good. So this is the giant sporangia or spherules of coccidioid mycosis. They're very distinctive, pretty large. And again, if we use the staining, you will see them. You can see here there's a lot of spores inside it. So this is coccidioid mycosis. One more. Okay, this is very distinctive. The condominium. Lots of organisms, thick capsules. I need to give a hint.
Crypto.
Cryptococcosis. So there's the two patterns of cryptococcosis depending on how the host immunity reacts. Sometimes the granulomatous pattern, you find a lot of granuloma cells and like histiocytes and neutrophils and very little organisms. And when you can identify them with the GMS stain or a mucic carmine for the capsule. But if the patient has poor immunity, you would see less inflammation and much more organisms, as you can see here in this case. Very good. Next case. Let me look for what we need to see here. Is it this part or is it this part? That has a good features. Oh, look at this here. You can see fungal organisms, hyphae, and if you can notice, they are following blood vessels. Trying to find some more for you here. It's a very poor slide.
Is this Lobo?
It is lobomycosis, correct. That's a correct diagnosis. It's lobomycosis, but I tried to identify more organisms. So it is lobomycosis. If you can see here, the pattern, they follow each other, some small rounded cells. So yeah, very good. And moving on to the next one. Oh, more here. More lobomycosis. Okay, so very good. Moving on to our next case. Let's see here. Okay, this is a nice one also. What are these? Leishmaniasis is very good. So you got your giant cells and foamy histiocytes with organisms around the cell. Very good. Moving on. Sorry, I'm moving fast now because we're running out of time. Next case. Okay, so this is a nice one. Let's see this part. Okay, very good. What's going on here in the blood vessels? Anyone?
Looks like they're pretty clogged.
They're pretty clogged. Very good. So there's again coagulopathy, a lot of bleeding in the epidermis. And oops, what is this?
Tongitis, right?
Tick bite.
It's a tick bite. It's a tick bite. So tongitis, usually tongue is pretty harmless. It's just gonna burrow into your skin and it's gonna like lay its eggs and just survive there. Tick is gonna bite you, and when you try to take the tick off, part of its mouth and sometimes even its head here, because it bites so tight, it would lodge its head in your skin, and you would see it even on H&E section. So pretty gruesome. I don't know what this is. Let's see. Oh, okay, so this is because I showed a couple of lobomycosis, and this is the GMS for the lobomycosis. Sorry, so very good. So I don't know why it got here, but yeah. So this is the GMS for the earlier lobomycosis we saw. I don't know why I have 3 slides of lobomycosis. I usually don't repeat myself, and I apologize for that. Okay, so Congiosum, very good. So this is acral skin, and you can see the organism inside the acral skin. You can see it with all its features and glories. The GI tract, the muscles, the thick cutaneous wall, everything. Very good. Here. Can you please close your audio so we can focus? Okay. So what is this? Onchocerciasis, very good. A large bowl of males and females all together in an orgy. Next case. Can you please close your audio so we can listen? Okay. So what is this? Again, neutrophilic and granulomatous infiltrate. And we got these organisms. So now we moved on from tiny stuff like viruses that you can't even see with a microscope to microscopic things like, bacteria, then larger ones that are larger than cells or as big as cells like fungi, and to organisms that are pretty big. So schistosomiasis perhaps, and very good, Amy Wang. Very good. So schistosomiasis. So this is Schistosoma hematobium, given the side spines that it has here. Schistosoma japonicum usually doesn't have spines, and the hematobium usually has a spine inferior lateral to the organism. So this is Schistosoma hematobium. Okay, what is this? Low power diagnosis.
Crusted scabies?
Crusted scabies, very politically correct, I would say. Not just correct, very politically correct, I guess, because the old name was Norwegian scabies. So crusted scabies, you can see here. It's like another type of condominium, if I may. See, at all levels, we got a lot of mites. Very good. And when you don't see mites, you see their remnants. Actually, nice to see this because very often, if you're thinking of your exams, yes, think of this when you think of scabies. But if you want to be a derm path, think that of these things, like the scabies feces and the pigtail parts of scabies that remain sometimes, because on histology that's what you're going to see most of the time rather than you're going to see real organisms. So think of these when you think of the scabies on the microscope. Very good. Pigtail from Malleum and Nodulum. Okay, this is our last slide, but one of the more interesting ones. Can you tell me what organism this is?
Reticulosis?
What? I couldn't hear. So it's a morulating, and again, what's the organism? It's protothecosis, very good. The morulating protothecosis. So yeah, I guess, and that's the last slide. And by all means, this wasn't, let's say, a comprehensive presentation. We didn't discuss every single organism. I apologize for some. I mean, I feel bad because I gave you 3 slides of Lobo. Actually, it was 2 mostly because one of them was the GMS. But for once, I became a little bit redundant today. So please let me know if you have any questions regarding any of the cases or any of the infections, or if you have any suggestions for our future talks, please let me know. I'm happy to listen to you. For once, I actually finished earlier than I'm supposed to. So I would love to hear any comments. If not, thank you for attending, and we'll see you in our next meeting. Yeah. And very good job for those who have been answering a lot today. You make the lecture fun to give.